So I also heard that there was a startling and surprising study that came out this year.
Yeah, there was a study that was pretty much the buzz of the conference. People were talking about it on a daily basis. It's called Switchmark, and it was dealing with icentra, the first of a class of integrace inhibitors that became approved. And it was approved for people that were experienced or have resistance to other medications. But this study was for looked at people that were on stable regimen with kaletra with background nucleosides. And they were randomized to either stay on kaletra or be switched to icentra. And what the study showed was that icentra was not non-inferior to kaletra. In other words, kaletra, the people that remained on kaletra, more of those individuals maintained undetectable viral loads versus the people that were switched to icentra. And in looking back at the study and the trial, it's not that icentra is a problem drug, but just the study itself was poorly designed. And generally, in terms of the standard of care, when a person switches one medication, they need to switch at least two. Right. And that was not included in the design of the study, and that's why kaletra looked better.
And so, in your opinion, that kaletra is not a superior drug?
Well, it's hard to compare apples and oranges. Sure. I mean, kaletra causes a lot of elevated blood lipids, like cholesterol triglycerides. It causes a lot of diarrhea. And this study had showed that icentra was better in terms of better tolerated by patients. Also, for people that switched icentra, they had an improvement in their cholesterol triglycerides. And then there was another study with icentra. It was called StartMark. And a study another study that we were involved in at NorthStar, where newly infected people go on a treatment of icentra with Truvada compared to an atripla-like regimen, and people that were on this study did better than the standard of care of atripla. In other words, people that were on icentra looked better. That those individuals had better, more easily tolerated medications. They had less problems in terms of lipids, and the efficacy was very comparable to atripla. And at CROI, they presented 96 weeks of data. So it just inspires physicians practicing using icentra. It just was very motivating in terms of seeing how durable icentra can be as a treatment.
As some follow-up questions about icentra, I heard that there's some interesting stuff about naive patients. Is icentra used as any of the PrEP or PEP in these studies that are being done, or is that
Well, that's a really interesting question. From an earlier study, patients that were put on icentra compared to Sestiva showed a much more rapid decline in viral load.
Wow.
In 1/3 the time that it gets, so viral load gets undetectable on average of, say, 8 weeks for patients on icentra, newly infected, and patients that were on Sestiva.
How long?
And so, as a possible PrEP, it hasn't really been studied, but there was a lot of information about PrEP during the conference.
But you were saying that icentra is used in naive patients now, then?
It's not indicated yet. It's been studied, and the StartMark was a group of patients that were naive. As I mentioned, they presented 96-week data about that, showing that if it gets approved as for naive patients, that it could be a very promising option for individuals that are first starting therapy.
Is this something that is being practiced? Is this something that's practiced at NorthStar?
Well, if it would be practiced at NorthStar, it would be offline. In other words, because it's not indicated by the FDA to be used as first line.
Sure.
But the data is out there, and so there might be physicians, and we hear about some physicians that are using it in that regard, especially people that may not be able to tolerate atripla.